Hello. Again, this is a review for cardiology for internal medicine board review. Most of those examples will be to focus on the topics that will be very common on the board, also in the ITE exam. We're not gonna dive in details, but this is some kind of an appetizer for you guys to rock and roll. Coronary artery disease, one of the most common topics on the test. You will have at least 10 questions about stable angina, unstable angina, STEMI, non-STEMI, um, not only diagnosis, and there is an AKG there that you need to pick it up quickly. Also, they will focus on those mortality benefits, medications, duration, onset of those medications, some complications after the STEMI, mechanical or arrhythmias. They may give you one of those scenarios that the patient already had an MI and now he's taking aspirin or dual antiplatelets, was on beta blocker and statin, and he still has like normal high blood pressure. And they will ask you tons of options there. What you gonna do? Are you gonna stress him or do a treadmill test or send him for coronary CTA or reassurance? Usually the missing piece is the ACE, so you need to add an ACE there. So you need to know those medications and the mortality benefits for aspirin, beta blocker, ACE, and statin, high dose statin. Um, they may ask you about what's the best test to do for this patient. A patient came with angina, chest pain, or exertional dyspnea, or angina equivalent, and they will gonna tell you, okay, what's next? You need to understand the rule of simple AKG, 12 lead AKG, stress test, either pharmacological or treadmill, and the thallium scan or ring adenosine test. You will have some questions about acute coronary syndrome, either for medication treatment and the role of anticoagulant, heparin infusion, enoxaparin, sub-Q, or going for cardiac cath, and how urgent or emergent is the patient need to be in the cath lab, and differentiating STEMI from non-STEMI and MI type 2, hypertensive emergency, and troponin leak, and demand ischemia. You may see some AKGs that only spot diagnosis for those like RV infarction with an ST elevation in RV4. They may give you some AKGs about posterior wall infarction and other AKGs for post-infarction like aneurysm or complication. Um, After successful vascularization, you may have some AKG as a follow-up. You need to know that at least the ST elevation must drop around 75% if it's revascularization, around 50% after thrombolytics, and around 25% if was managed only medication. Um, Again, the complication arrhythmia, and you will have very likely you will have it comes every time, the benign idioventricular reperfusion VTAC. This is benign. It looks like a VTAC, runs of multiple PVCs, two or three of them, with no signs of hemodynamical instability, or most of the time it's just seen on the monitor after full revascularization, or patient underwent either thrombolytics or PCI, and you will see those in the monitor, but the patient looks stable. Those are just benign idioventricular reperfusion VTACs. We don't do anything, just reassurance. Mechanical complications, and here is timing is very important. This has happened after like 1 day, 2 days, or 3 days from the MI. And what's the symptoms? Most of the time, there is symptoms and signs of heart failure, and the question will be, what's next? If it's pericardial effusion, you need to do yes urgent pericardiocentesis and take the patient to the open heart surgery and fix the if the patient survives, they will fix the wall rupture. Most of the time, those patients are unfortunately die. Um, Maybe VSD, that's something you, yes, there is a chance that can be repaired. And maybe valve rupture, like mitral valve rupture, and you will know that during the transient time or the temporary measures, you can use beta blockers, vasodilator, afterload vasodilators, and interaortic balloon pump. Valve clip can be used also as a temporary measure. Heart failure. You will have tons of questions about heart failure, management, the use of medications, the use of GDMTs, all of them. Usually, one of them is missing on there on the passage, so you have to add that medication either in Entresto or ACE if the patient is not on any of those, or maybe a beta blocker. The indication for the use of the devices: ICD, CRTD, SGLT2 inhibitors. Beta blocker or ivabradine, one of those questions will be there also. Uh, Takotsubo or stress cardiomyopathy, you may have one or two cases. One of the cases will be a I remember one of the cases was a patient was just underwent a surgery, total hip replacement. She's in her 80s or late 80s, and after the surgery, she had this chest pain, and EKG showed deep T-wave inversion V2 and 3. Troponin was positive. They did the cardiac catheter was non-obstructive, so the diagnosis will be Takotsubo, and the treatment will be the same as a heart failure. You need to give ACE, control the heart rate, and usually they recover. Um, Tamponade, you need to recognize that as an urgent and an emergency that the patients need to be underwent a cardiac echo, under evaluation his tamponading status. If the patient already tamponades, you need to do the pericardiocentesis immediately. Um, they may give you some signs like pulsus paradoxicus, and which is the exaggeration of normal. During the deep inspiration, there is more than 20 millimeter mercury.